Hi, it's Mark Chris from Memorial Sloan Kettering. Speaking today about information that I learned at ASCO this year, and also to begin a new series of talks about myth busting. And the myth I'd like to break today is that systemic therapies for lung cancers do not affect established brain metastases. So, what are the clinical facts? The first is that people that have a brain metastasis have metastatic lung cancer. And when you look at the natural history of disease in these people, what is the greatest risk to their life and health is systemic disease. Even in the presence of brain metastases, most patients still succumb from the systemic disease that they suffer from. So the approach to these patients has to be initiating the most effective systemic therapy as quickly as possible. So giving them a systemic therapy from the very get-go makes the most sense, not delaying that for any reason. Now, in doing that, I think gives you the best shot at long-term outcomes because, improving long-term outcomes, because you're treating the problem that's the greatest risk to them. So what's the biology here? This is where the myth comes. There's a difference between the blood-brain barrier and the blood-tumor barrier. And the issue for patients that have established brain metastases is that these therapies have to traverse not the blood-brain barrier, but the blood-tumor barrier. And in those cases, the blood-brain barrier is altered and drugs can penetrate. There's this idea that drugs can't get through no matter what. The penetration is different with the blood-brain barrier and the blood-tumor barrier. So the practical consequence of this is that as effective as a drug is systemically, it's going to be that effective in the brain. And that's exactly what was shown in the two trials presented at ASCO this year, one by Josh Sabari using the drug adagrasib. In that report, there was a response rate in the brain of 32%, a response rate systemically of 37%. Identical when you look at the confidence intervals, they overlap. The other abstract was by Dr. Nadal. There, the regimen was carboplatin, pemetrexed, and atezolizumab. And there, the response rate systemically was 45%, the response rate in the brain, 42%. Proving that point that it's as effective as a drug is in the CNS, in the systemic circulation, it's going to be that effective in the brain. So what I recommend is that when you have a patient with brain metastasis at diagnosis, put together your multidisciplinary team. You really need a neurologist, you need perhaps a neurosurgeon, and you have to decide, is there a serious or critical metastasis that demands immediate attention? Now, that's not usually the case, but when it is, you have to address that, and I encourage you to get the help of a neurologist or a neurosurgeon. The second thing is that you try to initiate systemic therapy with the best regimen possible as quickly as possible. Again, you're going to have the same chance in the brain as you're going to have systemically. It's important that you monitor the brain while you're treating it, and I would urge that you monitor the CNS whenever you're monitoring the systemic disease, and as we said already, that the benefit in one area is going to be mirrored in the other. I think I'm not saying that there isn't a role for local therapy. I absolutely believe that. However, I'd ask you to rethink about when that is going to happen, and whenever possible, think about approaching the brain as another site of oligo disease. So is it oligo persistent disease after induction or after a time on therapy? That would be the time to add radiation. Now, I'm not saying that the blood-brain barrier isn't important. It's very, very important, but it's critical for preventing brain metastases that have not yet occurred. Their CNS penetration of the drug is the and the effectiveness of the drug together are critical determinants. That's a different situation, not what I'm talking about today. I'm talking about people with established brain metastases. So I'm busting the myth. If a drug works systemically, it'll work in the brain, and you got to give your best drug. And I know these abstracts were talking about penetration to the brain and saying these drugs are good because of that. And yes, they are good, but please remember those response rates I talked about, they're still very low. What we really need are more effective drugs, and the more effective drugs are going to be the best way to control systemic disease, which is the real risk to life and health of our patients, and CNS disease. And they'll happen at the same time.